Well, hello, I'm Dr. Aguirre, and I'm here to talk about fertility, taking a closer look, and likely your wish upon making a baby. So we'll start off by talking about what is important now, preconception, meaning before getting pregnant. Then a brief overview of how fertility itself works, how infertility is then evaluated, and finally, how it may be treated. Okay? Now, fecundability is a word that means the chance of becoming pregnant per menstrual cycle. On average, there's a 20 to 22% chance of becoming pregnant per cycle. So, contrary to popular belief, it actually is not as easy as originally thought to become pregnant per cycle. Although possible, very few people become pregnant after their first try. Okay? So how can we stack the odds in your favor to make your wish come true? Well, first of all, it's good to know how fertility basically works. Briefly, you need the right equipment. Okay, you see, you need the brain, parts of the brain to signal itself via hormones, to produce more hormones, to signal the ovaries, to release an egg to be fertilized, and release more hormones. That egg then needs to travel down fallopian tubes, hopefully meet sperm in those fallopian tubes, come down into the uterus, hopefully an accommodating normal uterus, about 7 days after ovulating, hopefully you've ovulated, and implant itself into this uterus. So there's at least 5 steps that are important in fertility. At least. If an abnormality occurs in any one of these steps, you may end up with a problem of infertility. So we want to check hormones from the brain. We want to check egg quality, make sure that's okay. We want to make sure the plumbing works, both his and hers. We want to make sure that those little guys swimming around are plentiful and that they can move around and that there's plenty of them. And that the little incubator where it all grows is working well as it needs to be. Infertility is another word. By definition, means the failure to achieve pregnancy after 1 year of frequent unprotected intercourse or trying to conceive. If you're not pregnant in 6 months, don't worry that something's wrong with you. You just may need a little bit of patience. Infertility does occur in about 10 to 15% of couples trying to conceive. So if this is your case, you are not alone. Today we are seeing a decrease in fertility or an increase in infertility, likely due to multiple factors and changes in today's world. We're seeing delayed childbearing in couples. You see what happens here to fecundability. Remember, we talked about the chance of pregnancy per month or per cycle starts to drop down with age, especially after the age of 35. It goes down, it plummets there. Also, on a side note, the rate of miscarriages tends to increase after the age of 35, likely due to increases in genetic or chromosomal abnormalities. That goes up. We're seeing a decrease in fertility likely due to delayed childbearing, changes in roles of women today. There may be financial issues. Women may now be the sole breadwinners or having to work within the family unit. Also, women may postpone getting married. Marriages are being postponed as well. There's an increase in contraception use. There's an increase in more liberalized abortion today, and also increasing obesity in our country is seen. today. But what do we know about the major causes of infertility? Ovulation dysfunction is seen in 15 to 25% of infertility cases, usually hormonal. It can be related to age. Our hormones, we always talk about our hormones as we age and how they may go awry. Also, there's ovulation dysfunction associated with higher body mass index, increased obesity. Then there's tubal pelvic pathology seen in about 30% of cases. Making sure that those tubes are open is important. Then there's uterine and cervical abnormalities, but these are less common. They only make up possibly up to 5% of cases of infertility. Male factors. The male factor in infertility evaluations usually attribute 35 to 40% of cases. That's huge. So I don't see any of the hubbies or the fellas here tonight, but they are important in the evaluation of infertility because they can be a major factor in the cause of infertility within the couple. And then the rest of the causes are unexplained. We can't find anything, but we'll talk about what we do in that case, and that can be in up to 10 to 20%. So before we talk about these, let's talk about what we can do to optimize our chances of conceiving a healthy pregnancy and healthy baby, whether we're dealing with infertility or not, okay? It's important to, number one, try to have a healthy lifestyle. That was easy to say. Try to have a healthy lifestyle. Easy to say, not so easy to do. I know. But it's, unlike your age or your family history, something you can control. So try and exercise. Eat well. Body mass index of 20 to 25 has the best prognosis for a healthy pregnancy. How do you measure body mass index? You take your weight in kilograms, because we're doing kilograms now. You take your weight in kilograms and you divide it by how tall you are in meters squared. All right? 20 to 24 is an ideal weight. 25 to 29 is considered overweight, and 30 and above is considered obese. And those may have factors affecting your ovulation, your menstrual cycle, and therefore your ability to become pregnant. Eat wisely. Have folic acid, calcium, iron in your diet. How do I get folic acid? A lot of today's breads, cereals are enriched with folic acid. Not always enough if you're trying to get pregnant, so we'll talk about what else you can do, but a lot of these are enriched today. Calcium, of course, dairy. What if you're lactose intolerant, though? Well, broccoli has calcium. And believe it or not, even though you're lactose intolerant, you can still eat yogurt, which has an abundance of calcium as well. And it's good for your digestion. So you can try that, all right? But like I said, you can't always, and sometimes it's hard to get these in your diet alone. You may need to take a supplement, and I recommend taking a prenatal vitamin if you're interested in becoming pregnant prior to actually becoming pregnant. Oh, iron. How can you get iron in your diet? Red meats have iron. If you don't like meats, dark green leafy vegetables like spinach. So think of Popeye. Okay? Has lots of iron. My dad used to say it puts hair on your chest. I thought that was a good thing, so I ate a lot of spinach. But either way, iron is good for you. Can be found in spinach as well, if not red meats. Dried fruits like raisins, legumes. Okay? That's where you can find iron in your diet. Like I said, take a prenatal vitamin. After my husband heard this talk for the first time, he made sure that I took my prenatal vitamin. So ask your partner to help you, all right, to help you do what you need to do. And when you work together as a team, it makes it a little easier, all right? Avoid things that are harmful. For example, alcohol, tobacco, caffeine, and of course, illicit drugs. If you smoke, your partner should also, and your partner smokes, your partner should also quit smoking because it can affect sperm count. All right, and then studies have shown that if more than one person smokes in the household and you try to quit smoking together, success rates go up. Okay, so try and both quit together. Visit your doctor. Visit your doctor for a preconceptional consultation. Okay, what a concept. See your doctor before you get pregnant, okay? And that is because you may get a routine physical exam, make sure everything is normal in that sense. You may be due for your pap smear, or you may discuss any problems with your menstrual cycle, or just your menstrual cycle in general, figuring out when in your particular cycle you are the most fertile. Not everyone is the classic textbook 28-day cycle. Many women are, but some are 30-day cycles. I know many women are 30 days. Some may be 26 or even up to 35. And we can discuss, based on that regularity for you, where you're more likely to be ovulating and therefore where you're more likely to be the most fertile. Okay? We can also talk about any other problems that may need to be resolved prior to becoming pregnant, smoking, any thyroid issues that may need to be resolved before you try to get pregnant, and get all of those taken care of before you become pregnant. I did dedicate an entire slide to this, and that's because I think this is really important. De-stress, okay? I think that it is very important. You know, making a baby is supposed to be fun, really. And it's natural to become anxious when what you want isn't coming as easily as you would like for it to. But remember, stress can have physical effects that ultimately can hinder getting pregnant. So here are some ways to try and de-stress. Exercise, of course. Yoga is a type of exercise and a way to de-stress. Some people use meditation. That's a good way for them to de-stress. I put massage in there. Tell the hubby doctor's orders. He's got to give you some massage because that can help. Or any relaxation techniques that are safe that work for you. And then I also added sleep to this slide because I'm a strong proponent in getting a good night's rest. I think we forget about that. You know, with our day being so hectic and so busy, and we want to get as much as we can done in there, remember that sleep is necessary, and it's very important for your immunity and therefore your overall health. All right, so I think sleep should be in there as well. Say you've done all this. You've been trying for 1 year, and your wish for a baby still has not come true. Now, then again, this is where you need to revisit your doctor. You go to the OBGYN clinic, and you get further evaluations. These evaluations may be necessary to help manage your particular issue. Not everybody is the same, and not everybody has the same issues. Like we talked about before, there are several different causes of infertility. Let's talk about the male evaluation. We'll talk about this one first because usually it's the easiest. Basically, you need to know two things. Is he available and interested in sex? Usually the answer is yes. Okay? Number two, sperm analysis. This is done to look at the sperm count, to look at the motility of the sperm, to look at the morphology of the sperm, meaning the shape, to make sure that it's within normal limits. What we really want is something like this, but we'll take this because that's really all it takes. All right? The female evaluation is a little bit more complex. It consists of a need to take a look at ovulation factors like we talked about before, such as hormones, just collecting your menstrual history, okay? Taking a look at tubal factors, because that's important as well, the plumbing and the equipment, okay? Uterine factors, we take a look at that as well to make sure that that is also normal. Because remember, you need the brain to signal the ovaries to release an egg, and then from where that egg is released, more hormones are produced. As long as that cyst or follicle was normal, then those hormones help make sure that the uterine lining is maintained, especially after a pregnancy. You want that nutrients there for the fetus to grow, those hormones there. You want to make sure your anatomy is normal. You want to make sure that the uterus is fine, all the anatomy. This may seem like a complicated diagram, and it may be, but this is not what you need to worry about. This is what you let us worry about as the OBGYN, okay? Ovulation dysfunction. Well, one thing we can do to take a look at if there is an ovulation dysfunction is charting your basal body temperature. There's some inconsistencies in checking those, so another way is using ovulation predictor kits. These may be more consistent and easier to use because you don't have to say, well, that's temperature's kind of high for me, maybe I'll be ovulating. You kind of have to go back to the months before, how high was it before. Ovulation predictor kits, you pee on a stick and it tells you, yeah, you're likely ovulating now, or no, not yet. So those are available to look at ovulation and dysfunction. In the office, we check hormone levels, like we talked about before, those hormones that are released from the brain, or even your thyroid or the ovaries. And we also evaluate for possibility of diabetes, okay? Any other hormone irregularities, possibly having polycystic ovarian syndrome. This can definitely lead to menstrual irregularities, hormonal irregularities, and therefore infertility. And then, of course, help calculate if there's any problems with weight issues, obesity. All of these can affect ovulation, and sometimes even implantation. Next is tubal factors. We want to look at this because it's probably the most common female type of infertility. You need patency of the tubes, meaning you need the tubes to be open for business, okay? That's what I say. Blockage can be caused by a past medical history of infections, inflammation, maybe endometriosis, history of pelvic or abdominal surgeries in the past. Maybe you had appendicitis and had to have your appendix removed. Pretty much anything that can cause inflammation within the pelvis or abdomen. All right? This is a picture of what's called a hysterosalpingogram. It's an X-ray study, and it's where dye is injected into the uterus. This is what a normal uterus looks like, the shape of the inside of the uterus, the cavity. And then dye you see coming out of both sides where the fallopian tubes are and spilling into the pelvis. This means that the tubes are open for business. You can see in this picture here, in this image, that the uterus fills up and the patient's right fallopian tube fills up with dye and spills, but the left is not filling and is not spilling. So that indicates that this tube is blocked on the patient's left side. Okay, uterine factors may also affect fertility, and these include leiomyomas, also known as fibroids. You've probably heard of them as being fibroids. Endometrial polyps, these little dangly things here. So fibroids can be anywhere in the muscle, under, just above the surface, or affecting that lining that's very important in becoming pregnant, just like these polyps. So these are all uterine factors that may affect fertility. Uterine anomalies, where the shape should be like this, but we see it's maybe heart-shaped. Usually the heart-shaped uterus, they're okay in fertility, but they may cause some issues. Septate, okay, it's like a wall that starts to come down the uterus, separating it, compartmentalizing it. That can cause some problems with fertility. So this one just is a longer one than this one is. Sometimes you'll have a uterus that is bicornuate. It's got two horns there. Sometimes that causes problems with becoming pregnant as well. In addition to taking a good history and physical and the labs that we talked about, the evaluation may also include the need for imaging studies, such as an ultrasound, a sonohysterogram, which is an ultrasound where sterile saline is injected into the uterus. The hysterosalpingogram, like we saw before, where we looked for the tubes. That was a hysterosalpingogram. That's another imaging study that is very important. And the nice thing about the hysterosalpingogram is that when the dye is placed through the vagina, then the cervix, into the uterus, you can see the shape of the uterus and evaluate the tubes at the same time. That's what this is, okay? Hysterosalpingogram. That's another important evaluation piece. Hysteroscopy. Hysteroscopy is where a camera is placed through the vagina into the cervix and then directly looking inside the uterus for any abnormalities like those polyps. So that's what hysteroscopy is. Laparoscopy is placing the camera through the abdomen, taking a look inside the abdomen, and here we may diagnose reproductive tract abnormalities. Some women are born without, say, a right tube, and maybe that's why we didn't see dye go through there. Maybe it wasn't blocked, maybe you just don't have one. Or don't have an ovary on that side. There are some cases like that, rare but possible. More likely, though, the laparoscopy can be used to diagnose things like endometriosis. The nice thing about the hysteroscopy and the laparoscopy as well is that not only can it be used for diagnosis, but also for treatment. Say we go in and we look inside, directly inside the uterus, and we see a polyp. Well, we can remove it while we're there. Same thing with laparoscopy. If you have endometriosis and we see some implants there, we may be able to take those out as well. So that's really nice about these imaging studies, is that they can be both diagnostic and therapeutic. For treatment options, your doctor should try to find the cause, of course, in your particular case, give you specific treatments that you need, provide information about your particular diagnosis and the treatments for that diagnosis, and then, of course, provide any emotional support because, like I said, it's very natural to become anxious when what you want isn't coming as easily as you want, and you need to try and de-stress, but we can help you with that as well. It is important to treat the underlying disorder like we talked about, depending on what your particular case is, but educating you about fertility and educating you about your particular most fertile time, educating you about things like what can you do within your lifestyle that needs to be changed, what are you doing that's healthy and what are you doing that's not so healthy. We can talk about that because a lot of people don't know what they're doing may affect their chances of becoming pregnant or may affect their pregnancy once they do become pregnant. Then when we do talk about the lifestyle changes, that's on your part. Then you take that home and you work on that. But perhaps medications are needed, that we can help you with that. We can help you with something called Clomid, something called letrozole or metformin. These usually help induce ovulation if you need it. because these are ovulation induction medications. Metformin is another medication that isn't necessarily an ovulation induction type of medication, but say you have polycystic ovarian syndrome, it has been shown to regulate your menses. If you've got regular periods, you're likely to be ovulating. Well, if you're ovulating, well, then you can start getting pregnant if you weren't before. Then surgery is another thing we can help with. Laparoscopy and hysteroscopy, like we discussed earlier, if you have the need for removing a polyp or a fibroid. These are also available. Or maybe those little swimmers need a little bit of help with insemination. Insemination is a very simple procedure that can be done in the office where the semen is taken just like in a semen analysis. It's then washed, concentrated, placed in a vial so that then I may inject the specimen into the uterus directly, getting it closer to your egg. All right? So these are treatments that are provided by me, which are quite a lot, but still, if it's not enough or if it doesn't work, there are other options. And those include injectable medications, such as injectable hormones. These are hormones that mimic the brain exactly, tell the ovaries, okay, start ovulating, start making follicles. There's artificial reproductive technologies, such as in vitro fertilization. Those test tube babies, all right? And these are provided at subspecialty infertility clinics, okay? So if you need donor eggs, because we can do donor sperm here. That's another thing we can do here. We can do inseminations of donor sperm, but we can't do donor eggs. Say your tubes are blocked, you need in vitro fertilization to then place an embryo inside the uterus, since the sperm and the egg cannot meet where they normally would. They'd meet in a test tube. Or if there's a severe sperm abnormality where you really want to use that particular sperm, there's something called intracytoplasmic sperm injection. It's very costly, and you can imagine not used all of the time, but also possible. And then finally, of course, the other option is adoption. Okay? So the traditional algorithm is obtain a detailed history and physical exam. That's very important. Want to know your menstrual cycle. Want to know, are you having intercourse when you ought to be? And as often as you ought to be. I wish the hubbies were here. They'd like to hear that part. Ovulation, we're going to evaluate that via checking your hormones. Again, making sure your menstrual cycles are normal. Evaluating the uterine cavity, the tubal status, are they open for business? And collecting that semen analysis. Remember, that is very important. It can attribute 35 to 40% of the infertility cases out there. So we find something in here, we try to correct it there because that's more likely causing your problem, and hopefully we can move forward from there and you can become pregnant from there. If we do not find anything, remember those cases of undetermined or unexplained infertility, don't worry, you can still try to treat that with ovulation induction, meaning giving yourself a medication to try and make you ovulate more. We make more follicles in the ovaries, and we would take an oral medication for it, use timed intercourse and or insemination at the same time. Do that for up to 6 cycles and see if that works for you. If not, then you move into injectable medications with insemination, and then in vitro, or next directly to in vitro fertilization or some sort of artificial reproductive technology. So what medical treatments are available to you here with me? Well, there's oral medications, okay, Clomid, letrozole, metformin, like we talked about before. The nice thing about these is that they're oral medications, so they're easy to take rather than an injection. They're usually well tolerated, effective. We can also make sure that you are having a good response by doing an ultrasound looking at your ovaries once you've taken the medication to make sure that those follicles are being produced, that we're giving you the right dose. Often, you know, the first dose, say, didn't result in pregnancy or didn't work for you making follicles. We can increase your dose, take a look at your follicles again, and see what's best for you. There's usually low risks. These oral medications work indirectly to tell your body to make hormones to make you ovulate. That's how Clomid works. That's how letrozole works. Metformin, like I said, for some reason, which quite honestly we aren't exactly sure of, helps regulate you when you have something like PCOS. And of course, you need to ovulate to be able to become pregnant, and so that's how that works. The surgeries we talked about, those are also available here. The hysteroscopy, the laparoscopy, those treatments, if you need something like that, depending on what we find in your evaluation, are also available here. I put this in here because I think it's also good to know a little bit more about intrauterine insemination. If you combine the oral medications we talked about, the Clomid and the letrozole, where we're trying to make follicles, make you ovulate. If you combine that with insemination, pregnancy rates go up, period. So intrauterine insemination, like I described before, is a simple procedure that can be done in my office. You no longer need to go to the subspecialty infertility clinic out of town for this. You can now receive that treatment here. It has low to no risks and very low complications. Remember we talked about fecundability and the chance of getting pregnant per cycle is somewhere on average between 20 and 22% in the normal couple. Once we start getting into infertility, it's less than 2%. When we add Clomid to your treatment, we can bring it back up to 6 to 8% chance per cycle. When we add insemination on top of the Clomid or the ovulation induction medications, it goes up to 10 to 12%. So just by adding insemination, you can almost double your chances of pregnancy per cycle. So overall success can be very good. If a more complicated case, there's still other options like we talked about, the artificial reproductive technologies, such as in vitro fertilization, and these are pretty good. Those have success rates in some clinics as high as 50 to 60%, depending on where you go. So what can affect prognosis? Well, age. So you don't want to wait to seek help too long, okay? Otherwise, you'll end up like Marissa Tomei in My Cousin Vinny, where your biological clock is ticking like this. If you haven't seen that movie, you should. It's funny. Also, the type of diagnosis that we came up for you, that may be, depending on the degree of severity or complication, that may affect your prognosis. The length of infertility that you've had, the length of time, remember, the longer you wait, the more time you've had with this problem, the chances of success go down. So again, don't wait. Come and see me. Lifestyle changes. Cost zero. And that's a price we all can agree upon. But like I said, not always easy to do. But that's very, very, very inexpensive. Inseminations can be anywhere between $500 to $900, also with the visit. Clomid or letrozole, some sort of oral medication with inseminations, per treatment can be somewhere in this range. Injections end up being somewhere around this per treatment. Okay, so that's per cycle. In vitro fertilization, very expensive, as you can see. But what we want to know is, okay, what's it going to take for me to get pregnant, and how much does that usually cost? Because that's the ultimate goal. That was per treatment. Per pregnancy, on average, Clomid with insemination can end up costing quite a bit of money still. That's no chump change. That's pretty expensive, up to $10,000. Our first insemination here worked, so that was nice. But like I said, very few couples do get pregnant on the first trial, although it is possible. Injections with inseminations overall can end up costing about twice as much. And then things like artificial reproductive technologies, such as in vitro fertilization, can be very, very expensive, up to $50,000 or so. I'll take any questions if you have any. Sure. Yes, and because of those issues we talked about before, where there's a delay in childbearing, and like we saw with that chart there, as we wait to start our families, which is what many of us are doing in today's world with the changing roles of women, the infertility starts to go up because fecundability starts to go down as we age. And so after the age of 35, infertility really starts to plummet. And like I said, on a side note, other things start to increase at the age of 35, such as miscarriages, and that's probably due to increases in chromosomal abnormalities, something like that. But yes, we definitely have seen infertility on the rise, and we think that it's likely due to that. Another thing could be the issue of obesity increasing so much in the country. That affects our menstrual cycle. That affects our menstrual cycle to the point where some women aren't even ovulating anymore because they are making so much peripheral hormone, estrogen in particular, that it may block through hormone pathways our ability to have a normal menstrual cycle and therefore ovulate. So yes, so those are some of the reasons that we think we're seeing infertility on the rise. $400 micrograms daily. If you've had a problem with spinal cord defects, say this is secondary infertility, you've had a baby before but you can't get pregnant after that, then you want to increase that to 4 milligrams instead of just 400 micrograms. Most prenatal vitamins, though, have got you covered because most prenatal vitamins come with a 4 milligram nowadays of folic acid. That is a great question. And unfortunately, in the state of Wisconsin, there aren't very many insurances that cover infertility treatments. Many will cover diagnostics because you really want to know what's going on, what's wrong with, the picture. Could something be hindering your ability to become pregnant because there's other things going on hormonally that are affecting your menstrual cycle and your quality of life. You don't want to be bleeding 20 days out of the month. That'll prevent you from getting pregnant. Probably may not be ovulating correctly, and it might be due to a thyroid issue, and that could be, affecting other health issues. So some do cover the diagnostic management of infertility, but many do not cover fertility itself. So a lot of these costs are out of pocket. I have seen women take a lot of natural supplements, herbal supplements. Unfortunately, it's hard to comment on those because these natural supplements are sold without many studies backing them up as to their efficacy, their ability to work, because there's no patent on them. Companies aren't going to pay to have these studies done on them because nobody's making any money on them. But I will tell you, if these natural ways of getting the nutrients you need are there, I see no harm in that, because it's almost like keeping it within your diet or trying to get these things within your diet. And you can try those. But I would strongly recommend that you let your physician know what exactly it is you are taking in addition to any other medications. I think that that's important, to make sure that you're not giving yourself too much of certain things. There are some vitamins, believe it or not, that you can overdose on. Not very many. There's only like 4. A, D, K, and E, just so you know. Chart your menstrual history. Chart when you have your periods. The first day of your period is the first day of your cycle. So chart when you start your periods. If you think that your periods are pretty regular, just make sure. If they're irregular, definitely keep a chart of when your periods are coming, how often. They may fall within a normal range. They may not. Absolutely. Absolutely. And that's because obesity, we know, can affect hormones. So the fellas need hormones as well to trigger the testes to produce hormones and sperm and those kinds of things. And smoking has been shown to affect sperm count as well. So definitely, those can definitely play a role. There are some medications that can affect sperm count. Those would be some like anti-cancer medications. There are a few of those that can affect sperm count. But off the top of my head, there aren't many, but those can for sure. Not so much sperm count, but can affect libido, their desire for sexual intercourse, and maybe some issues with erectile dysfunction. Definitely with antidepressant medication or hypertensive medications, medications for hypertension in the male. That can affect those parts of the fertility. Remember, plumbing needs to work on both ends, so those medications may. Not all medications are necessarily bad for you when you're pregnant. Of course, we try to avoid any medications, especially during organogenesis when the baby's organs are being developed. But you have to weigh the risks versus the benefits. If you need a medication because your quality of life is horrible without that medication, you are better off taking that medication, becoming pregnant, because the risks are so low that the benefits of you actually feeling normal are significantly outweighing the small risk of it causing any problems with the fetus. Most antidepressant medications are called selective serotonin reuptake inhibitors, and there's only been one, for sure, a couple, though, possibly, that have shown perhaps some harmful side effects to the fetus. Paxil has shown some possible adverse effects on the fetal cardiac or the fetal heart. But the other ones, possible, but still nothing proven as far as adverse effects with those. So most of those are pretty safe. But you just have to talk to your physician, see how long have you been on them? Can you wean yourself off of them in the meantime? Do you want to do that? Do you want to try that? Or is there just no way that it would be a good idea for you? Okay? Sometimes, depending on your egg quality, because of that diminishing as we age, it may benefit you to go straight to the subspecialty clinic, and that's something that needs to be discussed on a case-by-case scenario as well, because I wouldn't want to waste your time by doing all of these medications, doing the timed intercourse, perhaps some inseminations, when your egg quality may not be very good. These things cost a lot of money. I would say if I believe your egg quality is not very good, that you should go directly to a subspecialty infertility clinic, because maybe they can help you increase your chances with those injectable medications, all right, that directly signal the ovaries to make more follicles. Of course, your risks of things like multiple gestation goes up, having twins or more goes up, or your risk of something called ovarian hyperstimulation, where your ovaries may become very stimulated and become large, maybe twist on itself. Very, very low chance that these things happen, but those risks do go up with those. So again, you have to weigh the risks and the benefits, but you may need, and you may benefit from going just straight to there, because your chances, say with something like this, would be better off going directly to that, or maybe perhaps needing donor eggs. Remember, we talked about possibly needing donor eggs. So if that's the case, you have much more or much better success rates with those treatments, those other options we talked about, and moving straight to there and not wasting any time, because usually with age we're running against that clock. And money. Money is a big factor too. So we'd get those hormones, and we'd get them during a particular time of your cycle. We'd see if the brain is producing the normal amount that we would see during that particular time of your cycle. If it's borderline, or we're just not sure, you're over the age of 35 and we want to make sure, we can get some other tests, things like Clomid challenge tests. These are tests where we sort of, not so much trick the brain, but we schedule the brain by giving you hormones during a particular time of the month, after checking it during a certain time of the month and checking it again, and see did the hormones respond the way we wanted them to. That will indicate, are the ovaries going to be responding the way we want them to. And now there's a new test out there, anti-Müllerian hormone, that can be measured as well. That can also indicate whether your ovaries or your egg quality is good. Okay. Thank you.
Thank you.
Mm-hmm.